Hello there, I'm Miranda Gretton, and this is Take a Moment with NCHC, the show where we talk to you and your colleagues about experiences that affect you. Listen on your drive between patients or in your downtime, whenever you get the chance to take a moment.
Hi Miranda, I'm John Webster. I'm the Trust's Deputy Chief Executive and Director of Strategy and Transformation. I've been with the Trust a little over a year now in that role.
So, John, have you always lived in Norfolk? Do you live in Norfolk, first off?
Yeah, I've never lived in Norfolk, actually. I was brought up in Suffolk, went to university in the Midlands to Leicester, and settled in that area. I spent a bit of time in Essex, which was just with a change in job role. But I've lived in Stamford in Lincolnshire actually since 2003. Moved there when my kids were very little, and they've now both grown and flown the nest. But we've decided to stay there. So Stamford's lovely. So I think we kind of took a decision that I do a bit of travelling, if you like, for the different roles that I've had over the years, and just sort of settle the kids in one area really. So yeah, we've been there for nearly 20 years now. Beautiful place to live, but
Gorgeous.
equally so's Norfolk. So all those places I was
True.
travelling into to work, probably Norfolk is my favourite of all of them actually. And I've worked in Hertfordshire and Bedfordshire and other such places, and in London as well. But yeah, Norfolk is lovely. But well, now that the kids have grown and flying off, it's a possibility in the future, I suppose, to think about moving.
Absolutely.
But no, I've never lived here.
What was your very first job in an NHS setting?
So I'd spent, after leaving university, 3 years with a management consultancy working on business cases for capital development, so new hospital buildings and that sort of thing. That was kind of my first introduction, I suppose, to NHS working. I wasn't going to go any further in consultancy without kind of direct NHS experience. So my first NHS role was a corporate business planning manager at the Derbyshire Royal Infirmary. So I was living in Leicester and travelling to Derby. I was in that role for probably a couple of years, then did actually get a job back in Leicester at Glenfield Hospital, which was a deputy director role of contracts and planning. But so I mean, my first experience working in the NHS was kind of 3 or 4 years working in the acute sector.
Interesting. So, not coming from a clinical background, but kind of flying into an NHS setting nonetheless. Did you find that was a bit of a hindrance, kind of not having ever, laid your hands on a patient, as it were?
Not really. I mean, the kind of planning roles I was in, I suppose, were quite well defined. But I mean, for me, it was really important to understand the clinical operational side of the NHS trusts. And so a lot of time for me was spent with clinicians, sort of developing business plans. It was at a time, I mean, you're going back, because I'm so old, we're going back to probably the early 90s, I suppose, or mid 90s. And it was just prior to Tony Blair coming into power as part of the Labour government back then. And that was actually a real shift in terms of emphasis for the NHS, and it was much more performance focused and managing waiting lists and how long you spent in A&E departments, which, we've had different flavors of government along the line, but actually those principles still hold. But that was kind of when it changed. So for me, in my roles, it's certainly early on in my career, a lot of time spent with clinicians, and that was enormously helpful because it's very difficult to have a conversation with a clinician if you don't understand a little bit about what they do, and actually you're not going to develop plans in isolation without sort of getting feedback from clinical staff. So it was brilliant for me because it wasn't a conscious decision really to enter the NHS; it just kind of happened. But actually, I landed in two very good roles early on in my career, and gave me a real broad sort of knowledge and understanding of how the NHS works.
Yeah, you're right. You can't really do any role in the NHS without having been and seen what's going on the coalface, as it were. So that must have been
Yeah.
really helpful. Looking at your career to date, then, what's the timeline coming from the Derby job coming into Norfolk? What was, like you say, you've been with the trust for a year. What were you doing just sort of prior to that?
Prior to that, I was the director of strategic commissioning for the Norfolk and Waveney CCG. So I came to Norfolk in 2017 So I got the accountable officer role at West Norfolk CCG as was back in 2017, and then the 5 CCGs in Norfolk and Waveney merged in 2019, I think it was, and I took that role at that point. And with the integrated care system developing, I took an opportunity really to come to the trust just a bit over a year ago. Discussion with Josie and I came on secondment to the trust just a bit over a year ago, but my contract is now with NCH&C, which is great. And I just really felt that, and I've said it to an awful lot of people since I've been here, just the nature of this organisation, the culture of it, it's incredibly welcoming to people. And I think people have a real sense of working together as a team here, and it's really evident. And support to our teams and staff is obviously at the forefront of what we try and do. So yeah, it's been a great time here, and I've loved my time in Norfolk actually. Often it's not, certainly in sort of more recent times, it's not been a conscious I must do this and then I'll move on to do that role and then this role. It kind of, opportunities present themselves, I suppose, and you just try and take the ones that you think work for you and work for the organisation. And it very much felt the right time to make a move to NCH&C when I did.
Interesting. So, given your experience with the CCG and us as a system across Norfolk and Waveney, I'm really interested to talk to you about that, because I think there's such a huge opportunity for collaboration there, and I personally feel that we don't tap into that maybe as much as we could. What are your thoughts on that? How do you see us working together more with the other organisations within the system?
I think as the work around the integrated care system develops, I think there's a lot of willingness to collaborate. And I think, we are a collaborative organisation. We're an integrated organisation in terms of our position with NCC and social care and working across the different sectors. It's going to be quite a difficult transition, though. I don't think, it's very easy to say, oh, yes, let's collaborate on things. But actually, when it comes to the crunch, even within the system as it's designed, and it'll become operational from the 1st of July, we are still statutory organisations and we have statutory commitments to meet. And so I think some of the challenges we'll face is, I hate to root it all down to money, but sort of money conversations are going to be quite difficult, I think, in a system that is very financially challenged, has a lot of operational issues, and actually some of the recovery phase post-pandemic is going to be less than straightforward. And so, people will know sort of growth in waiting lists and that sort of thing and how we're going to try and tackle those things together. My personal view is that I think we can offer more to our patients doing things together than we can as individual organisations just operating our own remit. And so part of my role is to actually think about how we develop those relationships across the rest of the system. There's a fair degree of trust that we need to build, and that's not just that organisations might not trust NCH&C at all, but we're not used to working in this kind of way. We are at the margins, but actually the whole principle of changing legislation around integrated care systems is that we formalise some of those collaborations together. So I think it's going to be quite challenging, but for me, I think it's a really exciting opportunity.
Yeah, I agree. And I think in terms of, those sort of financial conversations, you're absolutely right. But I think there's also a piece about that, about learning. We do a lot of surveys. We're always interested to know what the outcome of those surveys are. And I know that staff sometimes feel that they're telling us what they want to change and then, nothing actually happens. So I wonder if there is a piece there about learning from the other organisations and trying to capture that and formalize those processes, where we can sort of go out to other places, to the James Paget, to NNUH, and see what they're doing really well and what can we take from that and implement here, and vice versa. I mean, I'm sure that we're leading in a lot of areas and we could kind of push that learning out. So that, I think in terms of those collaborative conversations, that could be really interesting. I suppose it's just about how we facilitate that and whether that's an easy thing to do.
I think it is quite straightforward to do, actually. I think one of the problems I think we faced in developing the system is that we've possibly given too much time to structures and how organizations might work together in a structural sense. as opposed to, are there some priorities that we could work on together that are clearly going to have benefit for our patients? I would much rather start a conversation and get on with it and do some stuff together, and try it out, test it. If it doesn't work, we haven't lost too much. We can redevelop our plans and work in different ways, rather than waiting for these structures to be formed that we all need to operate within. So I think we're making some headway in that. I mean, we've got some really exciting projects underway. I mean, one in North Norfolk, which is really great, working across community nursing and practice nursing, particularly around wound care and frailty, and the teams coming together very much as a single team, as opposed to a set of community nurses, a set of practice nurses. Things like that are not hugely transformational, but they're beginning the journey of thinking, how we're going to work together differently in the future, and that's really good. We're also doing some work currently actually with the Norfolk and Norwich and with the Queen Elizabeth Hospital in King's Lynn, sort of setting priorities really where we can work much more closely together across acute and community services, and not the traditional how can we more quickly get people out of an acute hospital bed and back to home or into one of our beds in the community. But just thinking about how we can combine our staff resource working in different ways. And all of this comes from the benefit for the patient as opposed to the benefit for the organisation. And our staff work in that way all the time. They build those relationships. I think what we're trying to do is just sort of formalise those a bit more, encourage them to develop a bit more. And this has never been about sort of structural mergers or any such sort of discussion. I know some of that has worried staff in the past as well at NCH&C. Is it going to be a takeover by another organisation? But for me, it's very much about what we can bring into the system in support of the system, how we can work differently going forward. Forget the structure. If they change in time. But actually, the principle for us is all centred around the patient and how we can improve the experience for them.
That's really interesting. And I think you're right about it's building those relationships, and transformation it's a marathon, not a sprint, isn't it? I mean, it's never going to be an overnight thing. To transform something, whatever it is, it always is going to take time. It takes cultural change. There's a lot to it. Do you find that quite frustrating sometimes, the fact that that can take a lot of time?
Not that it takes a lot of time, but just that we progress it. And I think you're absolutely right. This isn't sort of some sort of explosive change that happens overnight. It's got to be built on. We've had sort of decades of working as statutory organisations in our own organisations. The era of payment by results actually drove the behaviours that you went within your organisation. You just tried to do the best for that organisation in financial terms and in other terms. What we're seeing now through the change in legislation is very, very different in terms of what the aims and objectives are for that, and that's going to take time to change. I think the biggest frustration is because I've been in sort of working in the NHS since 93, I think 1993, is the kind of perpetual change in government and slightly different policies emerging. And just when you think you're getting traction on something, there's another change that comes into play that we need to respond to within the NHS. That's more frustrating. The exciting bit for me is how you see the way our staff and our teams and clinical teams come together to work in different ways, with the objective being improvements for patients again. And that is exciting, but it will take time to implement. I certainly don't find that frustrating. I think the fact that we're making progress is very exciting actually, and I think there'll be much more of that to come.
I think we can definitely see a lot of that over the last kind of couple of years, even with the pandemic. I think actually because of the pandemic, maybe, the fact that we were able to turn on a sixpence and change some of our processes to fit in, to align with what was happening in the world so quickly. And that's amazing, the fact we were able to do that. But changing that focus from financial pressures to patient outcomes, obviously that can only be a good thing. Clinical staff and all frontline staff really are key to that, aren't they? So how are they involved in those conversations across the system, not just, like I said, responding to surveys?
Well, certainly at a system level, Venu, our medical director, and Carolyn in particular are very hooked into sort of system conversations around, clinical developments particularly. So there's been a lot of clinical engagement around the development of a system clinical strategy, which is sort of setting out over the next few years how clinical services will develop. So there's good engagement, I think, overall with clinicians. And similarly, internally, we're in the process of the moment of updating the trust strategy. That will involve a lot of clinical engagement over the summer and engagement with the wider teams within the trust. So we always need to take the opportunity to think about how we do it. But what we shouldn't do is sort of, I suppose, constrain clinical teams from trying to develop themselves. I'm not sitting here saying I've got all the answers in terms of how clinical services should develop, but I think we need to develop the right conditions for clinical staff and teams within the trust to be able to develop their services. I think what the legislation is doing is kind of giving us the permission to join with other partners and collaborate in different ways with other organisations where traditionally we might not have done. So that is, I think, is a bit of freedom to develop, I think, is what's important. And, we're certainly trying to embrace that within the trust. Getting the views of our patients too. So, where I'm saying I've not got all the clinical answers, because I absolutely haven't, part of my role is creating the right conditions to make those conversations happen. But equally, we don't want to be telling our patients, this is what we provide, so this is what you'll receive. So actually part of the process of joining everyone up in this kind of conversation is the patient experience as well, and the patient voice in how we adapt, change, develop our services in the future. So that's equally important to keep an eye on too.
There was a new format, patient voice at board recently, wasn't there? I know that some patients in the north came and they just sent videos, didn't they, on their iPhones, of them talking about the vaccination program and how it was going out to homes and how successful that had been. And I think that kind of thing really needs to be embraced, doesn't it? That we need those voices, but it's not just necessarily the people we've always gone to. Now we have the technology to say literally anybody, any patient, regardless of your mobility, whether you can make it into a boardroom on a particular day to talk to us, you can feed back. And it's listening to that and making sure that they're heard.
I mean, that's been a big change, I think, at trust board level. So each meeting now is opened by a patient story and people from the, colleagues from the places coming to present on their service areas. And you made the point earlier about learning, and only by hearing what people's experience is and thinking about how we can adapt and change things in response to that. But actually the pandemic in many ways made that easier for us to accomplish, because you're right, it's just we could meet people, and we have done, in their own homes, and hearing from them around their experience. So it's very powerful in terms of and really welcomed at board that we get the patient voice and we get to understand their perception of our services.
Why are you in a leadership role over just kind of getting on, coming in every day, doing your job and going home? Why did you want to become a leader? Why do you want to lead people? Why is it important that you help us through this period of transformation?
So I suppose to start with, Miranda, I suppose it was never a conscious decision to be a leader, but leadership for me is all about people, and it's about people before the organizations. I love being with people. I'd sacrifice a promotion for working in a better job, if you know what I mean, that I like doing with people that I like working with. And I think some of it for me is we can get tied up in organizations about developing plans and strategies and stuff like that. But actually it's those relationships with people, supporting people to do their jobs, that actually gets the job done. So for me, I take a lot of pride actually in the relationships that I've developed across the system. I'm always conscious I need to move those relationships to a different level. So it's one about, we talked a bit about building the trust, but it's now about making sure that we implement some things that are going to benefit our patients. I suppose my style is that, if there is such a thing as a leadership style, but one that I'm really intent on listening to what can change. I've never pretended that I had all the answers, and I don't think that's the right thing to do at all. I think I mentioned a bit about kind of creating conditions and giving people support and freedom to develop things. And I think that is really important, I think, to teams, that they know that someone's got their back, if I can put it that way, and is there to sort of support them and bring them on. So I suppose I'm quite facilitative as opposed to directive in style, but that's kind of a bit about what leadership means to me. It's people first before the organization, and actually supporting people to grow.
You've perfectly described a leader to me versus a manager. And I think it's that language is so interesting, isn't it? That we think of the exec as leadership. It's a leadership role. We talk a lot about the word leader and the word leadership, less so nowadays about the word manager. And I think there is a lot to be said for that in terms of how far we've come with making sure people come first. Before, I think it was, even 5, 6 years ago, I think people in managerial roles would have had quite a sort of feeling they have to be in control of everything and sort everything out and be that sort of figure at the top. And it was a very hierarchical sense. I feel like we don't have that so much anymore in the trust, particularly, which I think is great. Do you see that as well?
I do agree with it, and in fact, I've been the sponsor on a number of the leadership courses within NCH&C. And I think the way we talk about it as an organization is leadership at all levels. It's not just a director that can be a leader. Absolutely not. And it's about, again, sort of, thinking, yeah, we need to manage tasks to get jobs done, and there's things we need to do day to day that absolutely we do. But leadership is around creating those right conditions to grow our people. And that's true at every level of the organization. So certainly beginning of my career, things were far more directive in terms of command and control, and you need to do. I think what excites me about the changes we're going through, we've talked about the legislation changes, is giving that bit of freedom to develop things across the system, and you can reflect that back from the system into our organisation and right down through it. I was just so impressed when I joined the trust about some of the programs that have been put in place for our teams. And I mean, I did the staff induction yesterday, trust induction yesterday, and we were talking about those programs that are available to all people when they join us, and people are really encouraged to join those programs as part of their own development and to grow themselves. And it's a really impressive approach, I think, in the trust. And I know that people value going on those courses, so and they take something from that and they grow themselves.
Yeah, and I mean, like you say, we've still got tasks we need to complete on the ground. There's still things that need to be done, those tick box exercises that still need to happen. But I suppose the difference between a manager and a leader is that the leader will say, why don't you want to complete those tasks? What's going on? As a person on a personal level, what's happening? Really understanding their staff rather than just this job needs to get done. And I think that's where you really grow your people, isn't it? Where you have those listening conversations. Do you think there's anything we could do within the trust to make those better in terms of kind of one-to-ones, PDRs?
I think there's always areas where we can improve, certainly in terms of PDRs and the approach we take around appraisals and setting objectives. And there's always room for improvement. But I mean, I think I certainly see it across the trust that is kind of the approach that we take. So it is about developing our staff. I mean, I think as you were saying that, I was thinking you should never second guess what someone's going through either, and all that is part of building that relationship and understanding across the team sort of what people might be going through might be a reason for why a particular piece of work doesn't get completed or whatever. So it's not just jumping to conclusions, and you can only do that through regular contact. And I don't think there's necessarily a model that you can pull off the shelf and say that's how everyone should do it, but I think that kind of contact and sort of understanding, starting any one-to-one with how you're feeling, as opposed to why haven't you done that piece of work, it's just to be encouraged, I think.
Thank you for listening to Take a Moment with NCHC. If you've enjoyed this podcast, please visit the podcast intranet page to leave a comment and for details of our other episodes. You can also follow NCHC on all social media channels.